guys, Dr. Chad here today with another interesting case that I wanted to share. Again, the importance of these cases is to give you an idea of what it's like to see me in clinic, but also to stress the importance of what doctor you see, how important it is, and making sure that you have a medical provider that is navigating you through the medical course to avoid for some of the complications which we'll discuss. Today's case is an issue with someone's low back. It is a patient of mine that suffered a trauma and ended up with a herniated disc at L5-S1, which is the bottom portion of the spine. As has been well documented, the disc is the shock absorber filled with a jelly substance held in place by a rubber band. And if it ruptures, it hits the nerve, which is right here, and that causes the shooting pain down the leg that many people call their sciatica. L5 goes to the outside of your leg, S1 goes to the back of your calf and into your foot. So what we'll see, this is the MRI of this patient done after the accident, and what we're looking at here is what's called a sagittal film. So this would be the back, the front side, the back, the front side, bone, disc, and you can clearly see the difference between that disc and that disc. This is a normal disc. It's nice and plump, kind of looks like a hamburger with the meat in the middle and the bun on the top and the bottom, and you can see this disc is worn out. The biggest problem with this disc is behind it you have the herniation, so the disc material is pushing backwards. This image here is what we call an axial, so it's looking down the barrel. So this would be the front side, this will be the back side. You can see there is the disc material sticking out, so here's the holes where the nerves are coming out. This patient had very classic, what we call radiculopathy symptoms. So pain in the low back, shooting down the legs, worse with coughing, sneezing, lifting, walking. He had appropriate treatment, so we did physical therapy first. We did injections, which gave him some short-term relief, but it just didn't last very long. The way we do the injection is basically come in from both sides and put numbing medicine and steroid where the nerve is pinched. So after the injections didn't work, physical therapy didn't work, medications didn't work, then I went to send him to a surgeon. Unfortunately, he chose his own surgeon and did not choose the surgeon I sent him to, and he subsequently got a lumbar fusion. I'll show you those pictures in a bit. My first issue is I thought that possibly he could get his relief without a lumbar fusion with maybe what is just called a laminectomy discectomy. So what that means is shaving the bone and then shaving the disc without introducing hardware. That would allow decompression of the nerve. When you do a fusion, they come in from the front or the side and they'll put a spacer where the disc is. They should remove the disc, and then they'll put rods and screws from the back side down the part of the bone called a pedicle, so a pedicle screw. The goal of that is you're trying to accomplish the height that you see here. So you're trying to separate the bones and you're trying to stabilize to open up the hole or the foramen where the nerve exits. So this is the same patient. This is the MRIs of his back after he had the surgery. I want to point out before the surgery, he had numbness and weakness in both legs. After the surgery, pretty much everything was unchanged, still had numbness and weakness. What you're looking at here, again, is a sagittal film, and then you're looking at an axial. First thing that literally and figuratively sticks out is you can see the disc material has not changed. You can see this dark area here, which represents the metal spacer that was put in. You can also see where the rods have been introduced. The problem with this surgery is they, quote unquote, did a fusion. They put rods and screws, but you can clearly see that the disc material did not resolve. The reason for that is they did not remove enough disc material, and when they put the spacer in from the front or the side, they just pushed the disc material back outward. And you can clearly see here how much it is sticking out. When you look at this image, which is the axial, again, we're looking at things down the barrel. You can see how much disc material is in the canal now, and it's a little bit worse on the right than the left. These things are opposite, and I would argue that this image actually looks a little bit worse than what was done before. And this correlates with the patient's symptoms. So he's still having severe pain in his back, he's still having severe pain in his legs, and he's still having numbness and weakness in his legs. Unfortunately for this patient, he now has to undergo another surgery. And the problem is, once you have one fusion like this, to go in there and to do another fusion, the success rate becomes significantly less. From a pain standpoint, we can discuss things like spinal cord stimulators, pain pumps, medication management, but I always tell my patients I'm a neurologist before I'm a pain doctor, and when someone has this type of pathology and neurologic deficits that correlate with it, they have to deal with that first. And unfortunately, right now for this patient, his pain is the least of his problems, because if this doesn't get fixed, he can lose function in his legs permanently. So that's where we're currently at. So I hope this was helpful, and God forbid any watchers, viewers on my feed right now have similar problems. But again, I want to point out the importance of understanding your anatomy, the importance of having a relationship with your physician, understanding what's being done, why it's being done, different alternatives that could be done, because at the end of the day, this is his back and he has to live with it the rest of his life, and that can't be unchanged. So hope we can see you guys again. Hope you enjoyed this. Hope it was helpful, and I'll be back with a lot more interesting cases.